Okay,
Okay.
guys,
Hmm.
we're gonna continue our presentation here. So, I wanted to go back again because I think I skipped this part. Um, Acute postoperative pain guidelines. Most postoperative pain diminishes rapidly in the first few days. The CDC recommends short durations of opioids for acute pain. Less than 3 days is often sufficient. More than 7 days rarely needed. The reason I'm saying this part here is I see a lot of physicians when they write post-operative, pain medications, they write for a full month to the patient. Never do that. Not more than 7 days for major surgeries. Okay. Um, so why? Because there is a chance this patient will get addict to opioids. There is an incidence of 3 to 5% of these opioid naive patients that never had opioids before, to turn to opioid addicts if you do so. And sometimes you don't need to give opioids at all. You can just write an NSAID, prescription. Okay. Which of the following factors is likely to influence postoperative opioid requirements? Preoperative pain sensitivity, pre-surgical opioid tolerance or history of drug abuse, psychological factors, including catastrophizing and anxiety, and age. All of the above. The correct answer is all of the above can influence the postoperative opioid requirements. All right, opioids and chronic cancer pain. According to the WHO, which drug is not in step three? Codeine. So codeine and tramadol are in step two, a WHO analgesic letter. I want to say something important, guys. Very soon, this step two will be, will go to the wind here. It's not, there will be only step one and three. All right, just to let you know. And I don't have time to explain why they're doing this because it's a long story. But basically, there will be step one and step two, and that's it. All right, opioids and chronic non-cancer pain. This is very important slide. So the Danish Health and Mobility Survey uh, assessed chronic opioid use for non-cancer patients. More than 10,000 patients. All right. The chronic opioid therapy did not meet any of the key outcome of opioid treatment goals for pain relief, for improved quality of life, for improved functional capacity. What does this mean? It means that, if I have a patient with non-cancer pain, chronic non-cancer pain, I start him on opioids. Probably the opioids will help him out in the short term, but not on the long term. Did I see it? I've seen it all the time, guys. Okay? I've seen it all the time. These non-cancer patients, they never get better with opioids on the long term. At the beginning, it works like magic for them. All right. I cannot tell you, maybe first 6 months. All right. Afterwards, they will tell you that they become first, dependent on this drug. They cannot, leave it. They will tell you, I want to be on it. All right. But when you ask them about their pain level, it's the same. And I've seen it in my clinical practice over and over again. And that's why we're not recommending opioids for long term anymore for non cancer pain. Okay, I'm specific here. Chronic non cancer pain. Opioids are great for acute pain, are great for chronic cancer pain, but not for chronic non cancer pain. Okay, I hope this is very clear. A patient with, whatever, low back pain, for example. You can give him opioids for short term. That's okay, but not for long term, please. Okay, another important concept, which is opioid tolerance versus opioid naive. I mean, there are three definitions. I want you to stick with the lower one here. All right, that's the simplest one. Opioid naive are the patients who did not receive any opioids in the last 30 days. Urine drug testing. We have two types of urine drug testing. We have antigen antibody testing, which is called the ELISA. This is a simple, straightforward, cheap. In the United States, you can find it even in local pharmacies. You can buy it from a local pharmacy. And then you have the more sophisticated one, which is the gas chromatography mass spec. All right. Most anesthesiologists, they are aware about these terminologies. But this is a pretty sophisticated machine. Uh, the the drugs that are checked with the urine drug testing are amphetamines, benzos, cocaine, marijuana, opiates, and phencyclidine, okay, or PCP. So which opioid will not show up in immune assay urine drug testing? Fentanyl. Why? Because urine drug testing show up only actually the opiates, the natural opiates, such as morphine and codeine. And also, it can show up the semi-synthetic in large doses, like oxycodone in large doses or hydrocodone in large doses, but not synthetic opioids. Will not show up in immune assay. It will show up in the gas chromatography mass spec, this big machine here in the picture. And there are some, drugs that cause false positive. I want you to remember the most important one, ranitidine. It can show up as amphetamine, and there are others. Intrathecal pump. So, what's the role of intrathecal pump? Intrathecal pump are used in mainly right now for, cancer pain, chronic cancer pain, intractable cancer pain, and also for patients with spasticity. Now it's not used as it used to be for chronic non-cancer pain. So what is the idea beyond the pump? The pump delivers the drug directly to the dorsal horn in the spinal cord. So you need much lower doses than you need orally, and thus the side effects are much less. And there is a conference called the PAC. This is like every 5 years they do a conference, and they prioritize which drug is used, line one, line two, and so forth. So in line one we have two drugs here: ziconotide, which is a gabapentin-like drug, used for neuropathic pain, and morphine. Also, hydromorphone is in line 1B, and bupivacaine. So the question, for example, here, first line intrathecal therapy include all of the following, except C, clonidine. Clonidine is, as you see in line 2, as you see here in line 2. They like to ask these questions in the board exam. Okay, this is the end of first part, unfortunately. This is the second part of the lecture. First, we'll talk about morphine. And this is a case, to wrap it up, a patient on PCA morphine for sometimes started to become comatose. And basically, they're asking what is the cause of, this oversedation. It's related to the morphine 6-glucuronide metabolite, the one I showed you before, that's super analgesic, stronger than the parent morphine drug, and it accumulates in renal failure patients. Okay, some of the medications we use for PCA. I wanted to point out that meperidine is not supposed to be used for more than 48 hours. Meperidine is not a chronic pain drug. Okay, it can be used in acute pain, but do not exceed 48 hours, and basically in a patient with a normal renal function. And basically do not give more than 10 per kilo per day. Because I know OBGYN doctors, they love it. They prescribe it all the time for post-operative C-section and others. Oxycodone, it's a semi-synthetic drug similar to morphine. There are reports in palliative care where it causes lethargy and ventilatory depression in patients that are on dialysis here. Hydromorphone is another semi-synthetic drug that's 5 times as potent as a morphine, metabolized in the liver to hydromorphone 3-glucuronide, and has a better profile as the morphine in patients with renal failure. Fentanyl is a drug of choice in hepatorenal, failure. It comes in different forms, IV, patches, and also it comes in a sublingual form, like the one we have in Saudi Arabia, Abstral. Okay. But there are many other, sublingual forms available in the United States, at least four or five forms. Most of them are used only for cancer pain, incidental breakthrough pain for cancer pain, not for non-cancer pain, because of the high abuse potential. Meperidine. Which of the following conditions is most likely to result from prolonged use of high doses of meperidine? Seizures, because of the accumulation of normeperidine metabolites. I've seen it twice, guys, in my life. Okay, patients, and these were post-operative C-section patients receiving meperidine. Levorphanol. This is a drug that we used to use in the 90s and for cancer patients. And all of a sudden, it disappeared from the market. Nowadays, it has a comeback. This drug is a morphine-like drug, and it does have an NMD antagonist activity. It's a great drug, but it does have, it can cause psychomimetic side effects, such as hallucinations and delirium. Because it inhibits the uptake of the catecholamines. It's 10 times more potent than morphine. Tramadol is a step 2 WHO analgesic ladder drug. It's considered a weak opioid. It works by dual mechanism of action. Unfortunately, it can interact with some of the drugs like SSRIs and MAO inhibitors and can cause seizures and serotonergic syndrome. I had a case, a patient was taking Wellbutrin, bupropion, and then he went to his primary care and he gave him tramadol. Or sorry, I gave him tramadol, and he went to the primary care. He gave him bupropion, and he ended with a seizure in the ER. Okay, opiate withdrawal symptoms. You should be aware about these symptoms, guys. Patients usually vomit, they have diarrhea, abdominal cramps, their eye pupil opens up, mydriasis. Okay, usually patients taking opioids, they have meiosis, right? But their pupils start to dilate. So that's a sign of withdrawal here. And they get very sweaty or diaphoretic. And we have a scale that I mentioned early on, which is the COWS scale for opioid withdrawal, which is a very important scale they're using everywhere in the United States here in the emergency rooms. Okay, opioid withdrawal. So if you're having a patient that's taking benzos and opioids at the same time, and you're not sure which drug the patient is withdrawing from, So what is the most important sign that will let you know that the patient is having opioid withdrawal? It's basically hyperactive bowel sounds. Okay, that's the main sign. Medications used for opioid use disorder, we have buprenorphine, naltrexone, and methadone. Buprenorphine, there's a lot of interest on buprenorphine nowadays all over the world. It's the only partial mu agonist, and we mentioned that it does have a seeding effect as far as respiratory depression. The thing that I didn't explain to you before is it also has an anti-kappa effect. And this actually might be the reason it doesn't cause opioid-induced hyperalgesia. It does help with reducing the withdrawal symptoms and cravings when you're having opioid withdrawal. So it's used for opioid detoxification. It comes in different forms. There are forms for pain like the patches that we have in Saudi Arabia, and we have also Bilbuka, which is another form, sublingual form, but it's used off-label right now for pain in the United States. It's a pretty strong sublingual medication. Also, it's used for opioid use disorders. For example, you have the Suboxone, which is basically naloxone plus buprenorphine and Subutex, all right, which is buprenorphine without naloxone, and then you have Sublocade, which is an injection that lasts 30 days. Now, I want to talk about Suboxone because that's the most important one. Why they added naloxone? They added naloxone to as a deterrent, so the patient does not dissolve the drug and inject it, okay? Because it will precipitate withdrawal symptoms. So it's not used for any other purpose. So we use naloxone as a deterrent agent, that's all. Subutex, it doesn't have naloxone. So it has to be done under direct medical supervision, all right? Because the patient can inject it. He can dissolve it and inject it. These guys are, they can do anything, to get the drug in their IV here. And then right now they have an IV formulation. The subcut and formulation. Subcut formulation that lasts for 30 days. The Sublocade. Okay, so these are the different forms. I wanted to show it to you here. So there are ones for opioid use disorders and there are ones for pain. Don't mix them together. All right, like Butrans patch that we have in Saudi Arabia. This is not for detoxification. This is only for pain control. And by the way, for some reason, the patches in United States are basically the highest or the maximum is 20 mics. And they tell you not to use higher than that because of QT prolongation. While in Europe, they have these patches in much higher doses. They have it in like, I think 35, 52.5, and even 70 mics. So, I'm not sure. They're not scared much about, I guess, the QT prolongation. Methadone is an NMD antagonist drug used also for opioid use disorders and also used for chronic pain. Now, when do you use buprenorphine and when do you use methadone? Methadone is used for detoxification if the patient has a chronic pain problem. So if I have a chronic pain problem and I want to detoxify, it's better to use methadone than buprenorphine. I use methadone as a co-analgesic, as an adjuvant. Small doses of methadone with the main recipe to inhibit the NMDA, which causes most of the problems with opioids, and keep the methadone dose less than 30 milligram, which is basically the cutoff where methadone starts to cause all kind of side effects like QT prolongation and torsedipine. And I've been using this for quite a while, guys. Clinically, I never used high opioid doses beyond 100 to 200 milligram morphine or its equivalent in any patient, cancer or non-cancer. Okay. Of course, in cancer, it's the recommendation is not to use more than 90 milligram of morphine or its equivalent. But I do believe they're probably gonna come with recommendations for cancer patients as well. I think it's double the non-cancer. Anyway, using a small dose of methadone as an adjuvant or as a co-analgesics reduce the amount that you need of opioids. Same token like ketamine anesthesia. So giving a small dose of ketamine during your anesthesia will reduce your post-operative opioid needs. Ketamine, again, is an NMDA antagonist. Torsedipine can be caused by methadone, can be caused by other drugs like haloperidol and even ondansetron. And this can lead to what we call torsedipine, which is a kind of a ventricular tachycardia, and it's fatal. Opioid agonist antagonists. We have nalbuphine, butorphanol, pentazocine, mainly used for post-operative analgesia, opioid-induced constipation, and itching. All right, in Egypt, we use a lot of this drug, nalbuphine, because we have a company that's producing this drug here. So we use it even in palliative setting. It does have a respiratory sealing effect as well, same like buprenorphine. Unfortunately, it's a kappa agonist, so it makes patients a little bit dysphoric, all right? But otherwise, it's really a good drug, You cannot use, pure agonist with a partial, with an agonist antagonist, because it will counteract the effect of it. So we use it only to treat the side effects of, pure agonists. For example, you have a patient on epidural fentanyl and bupivacaine, for example, started to have itching. How are you going to treat the itch? You give a small dose of nalbuphine or Stadil. All right. So it's metabolized. Nalbuphine is metabolized by glucuronidation, conjugation, 75%. And it's 1-to-1 ratio with morphine as far as potency. Okay, another class of drugs called the pamorans, or peripherally acting mu opioid receptor antagonists. These are pure antagonists, but they don't cross the blood-brain barrier. They do not reverse analgesia. We use them mainly for opioid-induced constipation, such as methylnaltrexone, and another drug called naloxegol. There's a third one, it's called alvimopan. This is not for opioid-induced constipation, guys. Same category, but it's mainly used for post-operative areas. And there's a black box about this drug because it can cause cardiac complications. Relistor, you guys probably in Saudi Arabia have seen it. When I went to King Fahd, they had this drug, and I really urge the fellows to use it for opioid-induced constipation. It's a magic drug. And then we have naloxegol, Movantik. It's an oral pill, and alvelufan for opioid related illness. Okay, and this explains how these drugs work. Okay, how about pure antagonists like naloxone and naltrexone? Naloxone mainly used for opioid overdosage, while naltrexone can be used for opioid and alcohol addiction. Naloxone, which of the following chronic conditions would be an indication to prescribe a Narcan kit for patients on chronic opioid therapy? Chronic pulmonary disease, yes. Sleep apnea, obstructive sleep apnea, yes. Opioids with benzos and alcohol, yes. So we used to give these Narcan kits to the family member living with the patient in case they get respiratory depression. And there is intranasal form and there is an IM form. And the form below here is the one that we use in the hospitals, in the IV. I want to say when you give Narcan, give it very slowly in the hospital, all right, because it can precipitate pulmonary edema if you give it as a bolus here. So you dilute it in 10 cc and give it slowly here. Okay, naltrexone used for alcohol addiction and for opioid addiction as well. And it should not be started until at least 7 to 10 days of abstinence from the opioids. Now, there is something called low-dose naltrexone. A very small, tiny dose of naltrexone has been found to reduce the central sensitization seen in some cases like fibromyalgia and and complex regional pain syndrome. So this is Rivea 50 milligram. This is the one we use for opioid and alcohol addiction. Sometimes we use it for pruritus, in cholestatic pruritus for the people that remember my lecture here. Vivitrol is an injection, a naltrexone injection, that lasts for a month. Low dose naltrexone is one that we use for fibromyalgia and also for complex regional pain syndrome. Formulations of naltrexone, okay. Rivea, this is the 50 milligram tablets, and Vivitrol, which is an extended release formulation here, that also used for alcohol and opioid use disorders. Okay, nalfurafine is the only kappa agonist, and this drug is only used in Japan. All right, and it's used mainly for itching related to renal failure. Fantastic drug. Unfortunately, it's not FDA approved yet. All right, top side effects of opioids. We have at least 20 side effects. We'll talk about a little bit of them. Which of the following opioids doesn't cause meiosis? Meperidine. Meperidine is the only drug that causes mydriasis because it has an atropine-like action. The meiosis form, opioids is related to stimulation of a nucleus called Edinger-Westphal nucleus, which is basically part of the oculomotor nucleus here. It's the parasympathetic part of the oculomotor nucleus. Now, pinpointed pupil is a sign a patient is taking opioids, whether he's intoxicated or not intoxicated. Mydriatic pupil means patient is getting withdrawal from opioids. And that's why you find it in the cow's scale here. Okay, anaphylaxis versus anaphylactoid. I explained this several times. Anaphylaxis is a true allergic reaction, basically related to IgE, and it causes angioedema of the face. All right, this is allergy or anaphylaxis. All right, and usually it happens from the second exposure. The first exposure, you sensitize the body. Second exposure, you will have plenty of IgE, and thus you will have this anaphylactic reaction. Pseudo allergy is basically is idiosyncratic reaction. It's not accompanied with angioedema, and usually from first exposure. And a lot of people mix the anaphylaxis with the anaphylactoid or allergy and pseudo allergy. I mean, the treatment is completely different. In anaphylaxis, you're probably going to need epinephrine, while in pseudo allergy, you can get away with some antihistaminics. How about itching? Itching is a side effect. It's not a complication of opioids. All right. And it's treated with nalbuphine. Or if it's related to an epidural, you can give ondansetron. So ondansetron for opioid-related epidural or intrathecal use of opioids. Now, can we give antihistaminics? Yes, especially if you're using morphine, because morphine can release histamine from the periphery. But if it becomes persistent, you have to do an opioid rotation. Now, the opioid, there are new studies about opioid-induced itching, and they think it's not related to the mu receptors. It's related to a receptor called MOR1D, which is, like the cousin of the mu receptors. All right, and it's, found next to the mu receptors here. The other thing is itching in with opioids, guys. Usually, it's in the face, in the trigeminal area, and it's in the upper torso, like in the thoracic and upper back. Opioid-induced endocrinopathies. Opioids on the long term can cause, hypofunction of the hypothalamic pituitary gonadal axis, and can cause also hypoadrenal, hyperprolactinemia, and osteoporosis. So, what are the manifestations of hypogonadotropic hypogonadism? Usually fatigue, depression, anemia, reduced libido, erectile dysfunction, osteopenia. Guys, this is very important. I've seen it a lot of times in patients that are taking high opioid doses for long term, or taking methadone, for example. Check their testosterone. If they're fatigued, go ahead and check there's total and free testosterone. And there are different testosterone FDA approved formulations. I use this simple one, for God's sake. Just use the simple injection, 200 milligram every 2 weeks. Makes a huge difference to the patient. But if the patient has cancer, like prostate cancer, you have to check with your, oncologist. Opioid-induced nausea is related to stimulation of the chemoreceptor trigger zone, and it usually resolves within 2 to 3 days after starting the opioids. If it doesn't, go ahead and switch to another opioid. You can give antiemetics like ondansetron or metoclopramide. Constipation. I mean, this is the Bristol stool chart for constipation and diarrhea. We talked about it in the constipation lecture. Opioid-induced constipation starts from the esophagus and ends in the anus. It can cause actually something called gastroparesis. I mean, it affects the whole bowel. All right. So be careful about it. And it's the commonest complication of using opioids, and the body doesn't get tolerant to it. All right. Same token with meiosis. Like, I mean, when you take opioids, your eyes will always be constricted, no matter after 1 month, 2 months, it will always be constricted because your body doesn't get tolerant to it. That's why we start anti-constipation measures. The day we start opioids for long-term use, we use anti-constipation measures on the same day. We start Senna and Docostate or whatever, because we're, most probably the patient will end with constipation. Urinary retention is another complication related to constipation and related to the opioid. I want to say something, guys, and I've seen it a lot, especially in the post-operative period here. Patients complaining of pain post-operative, please go ahead and check the patient, because the patient might be complaining of constipation, not related to the site of the surgery. So if the nurse calls you in the middle of the night, please go ahead and check the patient, because we had cases like, patients they get overdosed with opioids, and the problem was not related to inadequate opioids. It was related to constipation or related to urine retention. Okay, very important, guys. All right, opioid neurotoxicity. I always explain the neurotoxicity as a spectrum, starting from tolerance, ends with seizures. And in between, you have delirium, you have opioid-induced hyperalgesia, you have myoclonus. NMD antagonist drugs actually reduces these neurotoxicity, all right? And also benzos. Benzos widen the therapeutic scale of the opioids, like the myoclonus. It will reduce this, but we do not like to add benzos to opioids because it might lead to respiratory depression. So that's why we like to give NMD antagonists like ketamine, methadone, magnesium. Buprenorphine is also an NMD antagonist drug. The microglial cell actually is the macrophages in your brain, and it keeps the glutamate in check in your brain here. Ketamine is a drug, a PCP derivative, NMD antagonist drug. It's not an opioid, all right? And it shows up as PCP in the urine tract testing. We use it as an adjunct to opioids, especially in anesthesia, okay, because of the NMD antagonist activity. Now, activated microglial cells will release tons of glutamate in your body here, and this can cause all kinds of syndromes: chronic fatigue, depression, memory loss, all this stuff, insomnia. And that's why we use ketamine nowadays in depression, intractable depression, all right, to counteract the effect of the glutamate on the NMD receptors. Opioid-induced hyperalgesia is another type of neurotoxicity, and we see it with remifentanil in particular, actually in infusions, all right? And it's characterized by diffuse body aches, respiratory depression, all right? It happens with opioids, overdosing with opioids. Usually the breathing rate is less than 8, and the treatment is Narcan or naloxone injection slowly, okay? Don't give it a bolus. And then you need to give an infusion over 24 hours. Otherwise, you will have a rebound from, re-narcotization